The first thing in templating is to have a long film, a scanogram like this, which shows the hip joint, the knee joint and the ankle joint. It lets you know whether it is a varus knee or a valgus knee, like in this one. The aim is to find out what is the mechanical axis deviation and to find out the valgus angle. Now you mark points: the center of the head, the piriform fossa, the center of the knee joint. Now the line joining the center of the knee joint and the piriform fossa will give you the anatomical axis of the femur, and the other line joining the center of the head of the femur and the center of the knee joint will give you the mechanical axis of the femur. And we know that there is an angle between these two, which is what we are interested and recreating in the valgus when we take the distal cut of the femur. Like for example, in this patient, this is the mechanical axis of the femur and this is the anatomical axis, and the angle we measured is 6 degrees. So we know that in this patient we need to create a 6 degrees valgus angle. Similarly, when we look at this patient, now this is a rheumatoid patient with a bilateral valgus knee, and again the anatomical axis, the mechanical axis, and the angle we have measured is 7 degrees. So now with the scanogram you have an idea of what is the valgus angle. You get an idea about whether there is any bowing in the anatomical axis of the femur. Is there any abnormality in the canal size? You might have a very wide canal, or at times you might have a very tight canal. You might look at some evidence of stress fracture in the tibia, or some evidence coming out with something in the fibula. So it gives you a general picture of what you are dealing with. Next, you go on with the proper AP and lateral view. We'll first look into the valgus knee. Next, it is important to have a good anteroposterior and a lateral view of both the knees, and the views need to be correct. For example, in a lateral view, the fibula should be posterior all in a posterolateral relation, and the patella should be looking very well complete from the side. Same is true for the AP view. We need to be careful if there is a flexion deformity. The fibula might be very high riding, as here in this patient, and other thing would be the rotation of the whole leg. The fibula normally overlaps the tibia on the posterolateral corner. Once we are sure our views are okay, we should be having an idea about what is the magnification like. Either we use a magnification marker or we have a standard magnification which is used in our institute, since they are going to be overlapping with the magnification which is already fixed on the templates. Now going stepwise, first we have to draw the mechanical axis of the tibia and the femur. What you can do is, at 2 points which are at least 5 to 8 centimeters away, try to find the midpoint and then draw a line along this, which will give you the anatomical as well as mechanical axis as far as the tibia is concerned. So you get a midline reference from this, and then once you draw a perpendicular from this, you get an idea about what are the type of defects which are going to be there. Normally valgus knees don't have much of a defect in the tibia as compared to varus knees, in which there would be a large defect. The same is required in the lateral view. Try to find out the midpoint. And then draw the long axis along this line, which gives you an idea regarding the axis, and then you can actually follow the tibial plateau and make out the smaller condyle, which is actually the lateral condyle of the tibia. This is the one which you would reference for the sizing, because the lateral condyle is always smaller. Now lift the templates. We can start with the tibia itself. By overlapping, you can have a gross idea. Now this is looking a bit small. Go to the next size. It's looking again a bit small. The same referencing you can get on the lateral view. Now 3 is looking small. 5 is also probably looking a bit small. And if you see, normally the tibia has around 5 to 7 degrees of slope, which you can actually recreate while templating. Now in this patient, probably the size would be 7. 5 is looking still a bit small. Let's pick the 7. Again, that's better. It is right on the margin of the bone, so it will rest on the good cortical bone once the cut is taken. So 7 is appearing good on the AP view. We go on the lateral view. Again, it's looking almost the correct size on the lateral view. So we are almost decided that the size on the tibia would be 7, and definitely there's going to be a slope of say around 7 degrees here. Next we go on to the femur. Most of the templating in a total knee is actually the size is decided from the lateral views. Let's see. Now this is 9, which is looking very large. This is 7, which is almost looking perfect, so we are very comfortable. Now this again is a view which is slightly oblique than which I would like, but I would agree with a size of 7 on the lateral view. Let's see on the AP view. It's pretty okay on the AP view also. So a size 7 on the femur also is doing a good job. Once we have to draw these, take the template behind. And this gives us an idea of the size of the femur. We don't want any overhang at any level. So that's the femur templated for a size 7. That's the tibia, and again the size 7 is looking pretty okay. We have to draw it. We are not planning out the articular surface size which has to be taken. So that's the tibia. We are okay with size 7 here also. Let's go to the lateral view. This will probably be the size, and you can see a angle which you can actually later on and be very sure that you're getting a posterior slope of around 7 degrees. That's the femur. It's looking pretty okay. So 7 here, 7 here, and that completes the templating. We have the size on both the sides, and we have looked into various other factors which could be associated. Now, the varus knee could be a slightly different one. Let's see an example of a varus knee. Okay. Now this is a case of bilateral osteoarthritis knee, a classical varus knee. Again, you draw the same axis first, and if you can see that the fibula is very high, and there was a flexion deformity actually in this patient, and if you actually cut at the proximal part of the fibula, you might get a very big defect on the medial side. There you see, that's from the top. And the other side, again you draw the mechanical axis. Draw perpendicular to that, maybe at the top of the fibular head. Once you do that, you get an idea that how much distance it is from the top on this and what is going to be a cut depth with the maximum, that is the tip of the fibular head, and even that might actually leave you with a defect which might have to be built up by either a cement or a bone graft or something else. So this is an advantage of templating, that you are ready preoperatively with various facts. And if you look at the lateral view again, now you can always look at the lateral condyle, which is the shorter one, and this is the one which decides the size. And it's very important to size them beforehand, because if there is an unusual size, small size, you better get them arranged preoperatively rather than get stuck. These are the various points in templating.